Well, thank you, Jens. Good morning, everybody. And it's a real honor to present here. It always is, and glad to be back. So just to jump into it, by way of background, adult spinal deformity, as we all know, is a very heterogeneous condition that produces quite heterogeneous associated disability, not only functionally, but also from a mental health standpoint. Surgical intervention has been demonstrated on numerous occasions to provide significant improvements in quality of life, especially relative to non-operative management. But that really begs the question is of what are the alignment parameters that drive disability and what are our surgical targets from a radiographic alignment standpoint? This is a case that many of us probably see in our clinics, mid-70-year-old woman with a pretty decompensated coronal and sagittal malalignment. And I'm hoping by the end of this talk, we'll have a nice understanding of what we should be shooting for from a surgical perspective. So let's start with the coronal plane, which it's a little bit less nuanced than the sagittal. So coronal alignment from a regional standpoint can be measured with the Cobb angles in the upper thoracic, mid-thoracic, lumbar, and also the lumbosacral junction. The global alignment is assessed by the deviation between the C7 plumb line and the CSVL. Another marker of global malalignment is a compensatory mechanism that patients have, which is they shift their shoulders, they tilt them to maintain their head over their pelvis. So assessing shoulder height and sometimes T1 or clavicular angulation can be a sign of coronal alignment globally. So do coronal parameters, are they associated with disability? And I would say yes. So this was one of the landmark papers by Glassman in 2005 that demonstrated that patients who have coronal malalignment greater than 4 centimeters compared to those who have less than 4 centimeters preoperatively have worse pain scores as well as worse functional scores, both in the SRS-22 as well as ODI and SF-12. More recently, the ISSG attempted to determine a target coronal realignment threshold, and they found that a residual postoperative coronal malalignment greater than 3 centimeters was associated with a worse outcome. And they did suggest that this was a potential realignment target goal for the coronal plane. More recently, 2023, the ESSG put out 2 nice papers with a more refined threshold, and they found that coronal malalignment independently affects patient-reported outcomes at around 2 centimeters of offset, and that disability functionally increases linearly with increasing in the CSVL. Additionally, those patients that were corrected to within 2 centimeters allowed for a significant improvement in both the SRS-22 and SF-36 scores. And this was associated with a 3.5 times greater odds of achieving MCID in the SRS-22. So I think based on some of this literature, I think it's fair to say that coronal realignment targets should include CSVL to within 2 to 3 centimeters. I think it's also important to keep the shoulders parallel to the horizontal and the floor, and then that could be accomplished by balancing your correction of the scoliotic curves. So going back to the patient that you may see in the clinic, this is a lady who our goal is to realign her to within 2 to 3 centimeters. She's starting at about 8 centimeters with a trunk shift to the right. She has a rigid deformity, and so we did this in a staged operation, L3-4 and 5-1 ALIF above and below a prior fusion. That was more to address the sagittal plane. And then we did an intradiscal osteotomy from the back at L1-2, and then I think realigned her appropriately in the coronal plane. But that brings us to the sagittal plane, and then we'll kind of dive into this, and this is a bit more nuanced. So alignment parameters, I think we've all been inundated with all these different ways of measuring the spine, and in terms of global assessment, there are several. One is the C7-S1 SVA. That was more the traditional one. There's now newer ones, the T1 or T4 pelvic angle. And then on the right, you see some of the regional alignment parameters in the sagittal plane. Pelvic tilt, sign of compensation for sagittal malalignment, L4 to S1 lordosis, global lordosis L1 to S1, thoracolumbar alignment T10 to L2, and then our thoracic kyphosis T1 to 12, sometimes T2 to T12, T4 to T12, a lot of different ways to measure it. But let's dive into each of these individual parameters and their associated disability. Original article, Glassman et al., one of the landmarks, first demonstrated that increasing sagittal global malalignment, C7, S1, SVA, drives disability from an ODI perspective, as well as general functional outcome scores, SF12. The T1 pelvic angle, ISSG, Themi protosaltus, demonstrated that about 20 degrees of T1 pelvic angle, so a sign of global malalignment, was also associated with severe disability. And then they proposed a target goal of less than 14 degrees. When it comes to the regional sagittal lumbopelvic parameters, L1 to S1 lordosis, also from Glassman, the more kyphotic you get, the worse your ODI scores. Schwab was one of the first to demonstrate that PI-LL mismatch above 10 degrees jeopardized ODI scores as well as all domains within the SF36 and the SRS22. And then he also demonstrated that pelvic tilt greater than 20 degrees also compromised functional scores globally as well as from a specific spine perspective. So I'll propose version 1.0 of sagittal alignment targets. These are the Schwab modifiers, PI-LL mismatch less than 10, pelvic tilt less than 20, and then a C7, S1, SVA less than 4. However, I think we all appreciate this is somewhat too simplistic. And this was followed up by more age-adjusted alignment thresholds, which we'll call version 2.0 of alignment targets. And while this does account, I think, for 50, 60% of the population, it really doesn't account for the extremes. And I still consider this a little bit too simplistic. And really, the reason for that is normal sagittal alignment is highly variable, and it's really dependent and driven and determined by pelvic orientation and shape. If we look at one of the original articles from Rousseli, where he did a prospective analysis of the sagittal plane of 100 healthy young adults, there's a huge variation in pelvic incidence, pelvic tilt, and lumbar lordosis. It's a bell curve. So average pelvic incidence is around 52, but ranges from 30 to 80. Pelvic tilt average is around 17, but it ranges from sometimes negative to about 30. And then lumbar lordosis on average is about 50 to 55, but ranges 20 to over 75. And you can see here that with increasing pelvic incidence, that also drives your lordosis magnitude that's needed. Patient with a PI of 30, a low pelvic incidence patient, a lumbar lordosis of 25, 30, 35 degrees may be acceptable, but that degree of lordosity would be a significant flatback deformity if it was in a patient with a pelvic incidence of 70. They need quite a bit higher lordosis. And this is also holds true for patients with their pelvic tilt. Low pelvic incident patient actually requires a lower pelvic tilt, whereas a high pelvic incidence patient, a higher pelvic tilt would be acceptable. So in addition to magnitude of lumbar lordosis, the pelvis also dictates the lumbar spine. And this is a nice article from Virginie Lafage, and they found that irrespective of your pelvic incidence, essentially everybody needs 35 to 40 degrees of lordosis from L4 to S1, and then depending on your pelvic incidence magnitude, your upper lumbar shape varies. And so this is what I would consider version 3.0 of sagittal alignment, that everyone should aim for an L4 to S1 lordosis of 35 to 40 degrees. Now, taking all this into consideration, lumbar shape, lordosis magnitude, as well as global alignment, the GAP score was introduced by the European Spine Study Group. And this is a really nice combination of all these things that when scored into different subgroups and totaled, you can come up with 3 different categories. Those patients that have proportion spines with a total score of 0 to 2, a total score of 3 to 6, puts them in a moderately disproportioned category, and a severely disproportioned is those patients that have greater than 7 score. They first demonstrated that these scores do correlate to mechanical complications, rod failures, and proximal and junctional failures. You can see here those that have severely disproportioned, the red, have mechanical failures upwards of 70, even 100%, where those that have moderately disproportioned scores are 30 to 50%, and those that are proportioned have very, very low rates. Now, if you look at what's needed to calculate this, there's a lot of equations, and from a clinical perspective, unless you have this set up in an Excel file or some app, this is quite difficult to use real time. So it's not terribly, it's good for, I think, research, but real time, say in the OR, this is a little bit more challenging to determine if you've realigned them appropriately. Another important classification to understand is Rousselis, and he also has focused on the importance of restoring quote-unquote normal shape to the spine. And it depends on the pelvic incidence, low versus high, and also where the apex lordosis should be in the lumbar spine. This, again, is a little bit hard to use real time, but it's important, I think, just generally to have an understanding of what these types are as something to keep in your mind when you are trying to correct it surgically. Multiple studies have demonstrated that Rousselis classification is an important one to follow to prevent mechanical complications. And the first study up there, and I quote, stated that ignoring this, or Rousselis classification, has a 3-fold risk of increased mechanical complications. Therefore, they recommend that this algorithm be used for the treatment of ASD. Now, the last sagittal alignment target, version 6.0, is the thoracolumbar junction's relationship to the pelvis. And this L1 position, I think, is important. It was brought up in Martin's talk earlier, the L1 pelvic angle. And you can see in this study from the Vanderbilt group how it's measured, the centroid of L1 to the femoral heads, to the angle to the midpoint of the sacral end plate. And they found that achieving an ideal L1 PA plus or minus 5 degrees decreased the risk of rod fractures and pseudoarthrosis. However, it did not, achieving this ideal L1 PA was not associated with patient-reported outcomes. Not terribly surprising because there's a lot of things that drive that. This is also a very nice study from a close friend of mine, Mike Kelly, looking at L1 pelvic angle and its relationship to the global alignment. So if you can set the L1 PA correctly, it ultimately sets your global malalignment or global alignment nicely, and also one target for minimizing complications. So in the sagittal plane, we have all these different proposed alignment targets, and so which one is truly best? And we have several studies that have done head-to-head comparisons. This one in 2019 at the Spine Journal compared the Schwab modifiers to the GAP score, and they found that both were capable of predicting mechanical complications. The GAP score proved to be significantly more appropriate because all the parameters were related to the individual pelvic incidences. A study from Lafage et al. In 2021 compared the Schwab modifiers to Rousselis, and as I quote, they both matching the Rousselis type and improving the Schwab modifiers had superior patient-reported outcomes at 2 years. Therefore, concurrent consideration of both systems may offer utility in establishing realignment. And then lastly, the European Spine Study Group study from this year compared Rousselis classification, GAP score, and this T4L1 hip axis, and they found that the T4L1 hip axis and the GAP score showed potential in predicting adverse events, and it surpassed the Rousselis method. So this is a lot. I do think there's more comparative studies that are needed, and there's other factors that likely drive outcomes here. But I've tried to take all the literature that I've read and created some algorithm, if you will, or some digestible table that I shoot for. And I think about patients in terms of 3 categories: low PI, less than 45 degrees, middle PI, 45 to 65, and then high PI, greater than 65. For my lordosis targets, for those that are low PI, I shoot for plus 10 to 15 degrees. So if they have a PI of 40, I shoot for lordosis of 50 or 55. If they're middle PI, I shoot for plus or minus 5 degrees, a little tighter window. And then if they're high PI, it's hard to achieve, 75, 80, 85 degrees, so I shoot for less than the PI by about 10 to 15 degrees. For all patients, I shoot for 35 to 40 degrees of lordosis from L4 to S1. The apex of lordosis, this is somewhat of an eyeball, but this comes from Rousselet's proposals. Pelvic tilt, I have a lower threshold for the low PI patients, so I'll do less than 10 to 15 degrees, a middle PI of less than 20, and then a high PI of 25, less than 25 or 30. And then for the L1 PA, I have it plus or minus 5 degrees for all patients, and T4 pelvic angle less than 14 degrees. So just to show you a couple case examples, this is a lady who I took care of. She had an L4 to S1 posterior instrumented fusion with radiolucent rods when she was younger, about 10 to 15 years ago. She had developed adjacent segment disease at 3-4. Someone did a standalone L3-4 ALIF, and then she developed progressive degeneration and decompensation in the coronal plane to the right, 4.5 centimeters. So clearly this is independently a driver of her disability. If we look at her sagittal plane, deceptively, her global alignment is okay, and it's because she's compensating. She's actually not terribly old. She's 55 years old. So the C7S1 SVA is less than 5 centimeters. But if we look regionally, she has very, very severe lumbopelvic mismatch. So she's a low PI patient, 41 degrees. Her pelvic tilt is 19, which by Schwab modifiers, which would be normal, but per our understanding of normal alignment, this is high. Her L4 to S1 lordosis is completely inappropriate. It's 13 degrees, and her global lordosis is 32 degrees. So again, low PI patient, these are my targets. And in her, because really the major issue here is L4 to S1 lordosis, restoring her shape, she needs an apex lordosis at L5. We ended up doing an L5 asymmetric PSO, extending up to T10. And with our sagittal global alignment parameters, we restored her T4 PA, L1 PA to our goals. Her lordosis, 55 degrees, plus 10 to 15, which is my goal for a low PI patient. And then if we look at her low lumbar spine, L4 to S1, 45 degrees, maybe a little bit too much, if you will. But the pelvic tilt was nicely restored with the low PSO to less than 10 or 15 degrees, less than 15 degrees. From a coronal alignment standpoint, the asymmetric PSO down below also helped bring her back into position. Her shoulders are level with the floor. She also has a little bit of a leg length discrepancy, as you can see, so I try to match it to the horizontal and not to her sourceals. Another patient that we can put this algorithm to test, a lady with de novo degenerative coronal and sagittal malalignment. You can see here she has a truncal shift about 3.5 centimeters to the left. We didn't talk really about the classifications of coronal malalignment, but this would be considered a Bow type C or an O/E type 2. And if you look at her global malalignment, she is pretty decompensated, 13 centimeters forward. And if we look at her lumbopelvic alignment, again, quite a bit malaligned. L4 to S1 lordosis, 17 degrees. She has a pelvic tilt of 27 degrees, and her global lordosis is also insufficient for her pelvic incidence of 50, at 40. She falls into the middle PI category, and these are my targets. And because of the concomitant Bow type C, O/E type 2, as well as the lack of lordosis from L4 to S1, I did an L3 to S1 ALIF to correct the lumbosacral fractional curve and restored the sagittal alignment to within a centimeter. And then if we look at all the parameters, pelvic tilt decreased to 20, which is on the top end of acceptable in my hands. L4 to S1 lordosis improved to 43. The L1PA and T4PA were within targets, and our global lordosis also was within plus or minus 5 degrees, which I was shooting for. The coronal plane, with the addition of a kickstand rod on the left side, overall improved her alignment, I think, respectably. So there's also a lot of other things that drive outcomes in these patients. It's not only alignment parameters. I think we're going to have a nice talk by Glassman more specifically on this, but the more and more we look into this, we understand that frailty, sarcopenia, osteoporosis are major drivers. This, I think, is still the black box. We're trying to understand how to measure it, how to take it into consideration, and use it in our planning. But I think stay tuned, this is the future. So in conclusion, appropriate realignment in ASD operations is critical for, in my opinion, short-term, but more importantly, long-term success. The durability of these operations is very key, also from a cost-effectiveness standpoint. Alignment targets have evolved over time, and I think we're pretty close, but we still have some refinements to do. Based on my understanding of the literature, coronal alignment within 2 to 3 centimeters globally is important, in addition to making sure their shoulders are even. And then in the sagittal plane, there's a lot of things that we can look into, but a combination of all of them likely plays a role. Shape is important. I strongly believe that. So understanding Rousseli, understanding the nuances, the gap score, the L4 to S1 lordosis of 35 to 40 degrees, I think is critical. And then assessing the thoracolumbar junction with respect to the pelvis and where that's positioned is also important. Other factors are at play, as we just mentioned, and may ultimately trump alignment. I think TBD on that. But ultimately, preoperative planning as well as intraoperative confirmation evaluation are necessary and critical. I didn't talk anything about what surgical techniques I think are optimal to achieve these. I look very young, but I'm a really dinosaur guy. I drive a stick shift car. I don't have any social media accounts, and I'm an open spine surgeon. So thanks for your time.
Wonderful, and just in keeping with the excellent presentations you've given generously so to our SSF venues. So let me ask you a question. There's some companies now that kind of purport this ideal of alignment goals met, yes or no, and they give us pre-contoured hardware that purports to have less hardware failures. In your experience, let's start with the latter first. How often do these actually match what the surgeon can achieve in surgery? How often have to be discarded and manually recontoured?
Yes, great question. It's a very nice, sexy idea in keeping up with technology in our time. There are challenges with them. I've dabbled with their use, but I have since gone away from them. Intraoperatively, many times they're too long or too short. And I think, unfortunately, they're being used as a form to get away from good carpentry. I'm a big believer that instrumentation is not what drives your ability to correct the spine. I mean, it's important, but you have to be able to release the spine through the disc, posteriorly, and that's how you're ultimately going to achieve the alignment that you want.
Great, and then I get to review a lot of articles. What do you think of articles where they basically state, have the surgeons met the alignment goals without any kind of a consideration of patient factors such as age, decrepitude, neurologic problems, etc. So is it fair to just have this kind of a dichotomous approach to alignment goals met yes or no as a quality criterion, or should we be a little bit more differentiated?
I think we should be a little bit more differentiating. I think it's one piece of the puzzle. Like I said, I think the biological factors here are not well understood. And I think for us to create a nice overall understanding, we need the alignment, some of these technologies, and a better understanding of the biology and how to optimize it. Right now, we're lacking on the latter.
So yeah, I had a great talk.
Can you use a microphone?
Of course.
Or I'll come here. I'll come to you.
Thank you.
Big SSF microphone. And tell us who you are. Who are you?
I am Alex Mojita. I practice down in Tacoma, and it was an excellent talk. When I look at parameters, it's really a discussion of the ideal in correction. But, I don't operate in the ideal plane. Most of my patients are osteoporotic, are sarcopenic, and so in terms of when I plan a case, I'm thinking about how to reduce the biggest complication in these situations is early failure of my construct or PJK. That's my essentially goal when I plan cases. So in your opinion, of all the parameters that you've discussed, excluding osteoporosis, sarcopenia, what do you think is the best predictor for reducing PJK?
Yeah, good question. So out of all the one, if I were to choose one of them, yeah, I would say I think it's the gap score, because I think that takes into account the low lumbar lordosis, L4 to S1, 35, 40 degrees. It takes into consideration shape of the spine, which I think should take into consideration the Rousseli. And if you get that right, it will put your thoracolumbar junction in the right position relative to your pelvis.
Alekos, this is a beautiful talk, a beautiful deformity talk, and it's so nice because just like you pointed out, coronally, right? There's a few things that you should look at. The bow type curves are great. Obeid is really great, and then sagittally, there's so many numbers, and I really like how you framed it in terms of like versions 1 to now. With the advent of the pelvic angles, right? T4 pelvic angle, L1, when you take your long film in the operating room, say you're going up to T4, and you take that long film and it's off, is there something that you do differently to match that? Or is it now just more predictive? Like say you already have your plan, you've already done your PSO, it closes, and your L1PA ends up being 8, and you really can't do much about it, and now you just know predictively to watch for in the future? Like, do you do something differently in the operating room based off of that information?
Yeah, that is a great question. It's very infrequent that I will. So it's very hard to correct if you've overcorrected. I think it's easier to do something more if you've undercorrected. So it depends on what you see. But yeah, I think a lot of it is predictive.
I mean, yeah, great talk. I have to say that it just got lost with every year, every 6 months, there's a new measure to prevent proximal junctional kyphosis and everything. For me, the big change was the EOS machine. And you start to examine the knee of the patient, see if there's a flexion contracture that drives the hip flexion. You can see, you look at the pelvic tilt, and you look at the overall alignment, and then you say, what it would take to get the correction? Is it just to work on the hip first, just by the total hip arthroplasty when they have, I don't know, they have hip OA or something like that? And what it would take to correct the pelvic tilt? And then you look at the pelvic incidence and different Rousseli classification, and then you try to match this and forget about this all the time. New angles or a new measurement that comes out every single week. Okay, so I cannot keep up with this. I couldn't keep up with this, all these new numbers.
Yeah, I hear you. There is a lot. I agree with you. Understanding the global, not only global spine alignment, but full body alignment is critical. And the EOS has helped to understand extra spinal deformities, because a lot of times those, if they're not addressed, can compromise the outcomes of a perfectly aligned spine. So yes, that's a great point.
Alekos, wonderful talk. I'm at the University of South Florida, where there's historically a lot of ACR. And I just wanted to ask, in the Rousseli classification specifically, there's an emphasis on maintaining the lumbar lordosis, the apex, at an appropriate level, and except for the type 4s and type 5s, usually that's somewhere below L4. Does this invalidate ACR at L3-4, L2-3 for you as a valid corrective move in deformity? Does that make sense?
Yeah, and the answer is yes.
Alekos, what compensation are you making for age in these patients? So in your table of considerations for what parameters you're aiming for and the different types. I didn't see age. And it worries me with respect to PJK because in addition to bone density, we have this ideal of what the corrected parameter is, but these patients, maybe the elderly patients, the goal isn't to achieve that and to accept a lesser standard. So how do you bring that into your consideration?
Yeah, that's something I'm still toying with, is the age-adjusted alignment parameters. I believe it, but I don't 100% buy into it. I think if you undercorrect even an elderly patient to those parameters, that puts, it puts tension on the posterior fusion mass, puts tension on the rods. That may cause rod fractures down the road. And it does stress the proximal junction. They may try to compensate and try to keep themselves up. They may be surviving, but surviving's not thriving. I think overcorrection in the elderly patients is probably more significant, partly because is worse. Yeah, partly because their minds and because of where they have always been forward, and and so I think in an elderly patient, it's important to prevent overcorrection. If you're going to undercorrect them, I don't think it can be very, very significant. It needs to be close to ideal. It's interesting, if I have a patient who has a PJK, say, and they fall forward, I just fuse them essentially in situ, because I think that's just where they want to be. If you try to correct them again and you straighten their thoracic spine and make it hyperlordotic, they're just going to keep falling forward. So I think it's a much bigger discussion, but yeah, the age portion of it, I think, is also somewhat of a less well understood portion of this.
I was going to say, there's some work for the ISSG that's just about to be published. It shows
1 sec. Nobody can hear you, even with your voice.
Okay. I was just going to say, the question is a really good one, and I think that different people have gone back and forth. So it was thought that undercorrecting, and there was some degree of, very elderly people, substantially undercorrecting. And what some public work that's going to be published shows exactly what you have. A little bit of undercorrection is okay, but it's a little bit. And it's so much more important to get the ideal alignment. Oh, okay. To get the ideal alignment than it is to go and shoot for undercorrection. So I think that the stuff that was brought to attention earlier, I think that many of us over the years, really did much more of our correction through the kind of mid-lumbar spine. And I think this gradual realization that you need this 35 to 40 degrees at the bottom is really, really important. And it's funny because I'm at a place where there's a lot of, anterior column release surgery done, which makes zero sense to me because, again, if you're doing a, L1-2 or an L2-3, ACR, it's recapitulating all the mistakes that we had learned through the years about how you really need to get your correction at the bottom. So I think the one thing that goes in my mind is that correction at the bottom outdrives, and if you're a little undercorrected, that's where you don't want to overcorrect them. But it's usually hard to overcorrect them if you get a good correction at the bottom. It's when you're trying to do something in the mid-lumbar spine that you're getting this non-physiological overcorrection that leads to the PJK. So I think that the question is a good one, but this thought that you can go, and that there was a little bit of that thought that was by our sort of MIS group of the ISSG, and what they found is we get much less PJK than you do because we do it MIS. It's no, you get less PJK because you are not correcting them as much, and that is that. And if you're fusing them in situ, you're not going to get the same degree of PJK. So I think that the lesson from this, and was brought up so nicely in the talk, was that where you get your correction and how you get the correction, particularly at the bottom, makes up for a lot of mistakes in other areas.
Outstanding. Must move on, and we have a great